Our presentation is on bioartificial organs. The technology for artificial organs has changed over the years. Sometimes the organs can be from tissue engineering, 3D printing, and even using the patient's own stem cells on a man-made structure. When printed, a CT or MRI scan from the patient can be used in order to make a mold for the organ. Harvard Apparatus Regenerative Technology, or HART, has made a trachea by taking a patient's stem cells from their bone marrow and placing it over a structure. There was a mesh made so that the cells could attach to it and begin to grow. It was placed on a rotating incubator until the trachea was ready to be implanted on the patient. In Switzerland, a heart was 3D printed and made out of silicone. The heart was the same size and shape as a human heart. It was tested, and the silicone does not last long enough as the organ begins to break down after 3,000 pumps, which is about 35 to 40 minutes. Artificial kidneys will be used to eliminate the need for dialysis as there is not enough donors to supply the kidneys needed. In one case, a CT scan was used to find the dimensions of a patient's organs so that an artificial one would match the size and shape of the original. One mold cannot be used for every patient as each person's body is unique and one size fits all will not be a viable option. In a study done at Harvard, MRI scans were used instead of CT scans to make a mold for artificial organs. Once the mold is fit for the patient, it can be printed. Another option is using stem cells. HART used stem cells from a patient's bone marrow and placed it on a tube made of mesh, seen on an image on the right, so that the cells could proliferate. The mesh was essentially basted with the cells. As the structure was incubated, the cells were able to divide, and eventually the entire apparatus was placed in the patient, instead of using traditional transplants. Since the cells come from the patient, it is less likely that the body will reject the new organ, and this patient received a trachea from this procedure. The goal kept in mind when creating the technology for a bioartificial kidney was the clinical trifecta, a heart-powered device that runs without batteries or other external connections that could introduce infection risk and which can clean the blood without anti-rejection drugs or blood thinners. Our technology has not reached the clinical trifecta but is getting closer each year.
In sonography, a bioartificial organ should not affect the image. Some parts may appear as artifacts, but the image should still be good. In radiography and CT, using automatic exposure control, or AEC, will result in an overexposed image with the presence of metal implants. This is because metal will absorb a large portion of the photons, causing the exposure to last longer and more dose be given to the patient. With bioartificial implants, this should be resolved as polymers absorb very little X-rays and react similarly to the organs that are in the body. In MRI, an image cannot be done if there is any metal in the artificial organ, stent, heart valve, or if the patient has had recent open heart surgery. For all modalities, implants should be made note of as it can obscure the image and pose problems for patient safety. Wilhelm J. Kolff is known as the father of artificial organs. He invented the first artificial kidney by building a rotating drum using scraps of metal, wood, and sausage casings. The sausage casing was used to make a semi-permeable membrane so that substances could still pass in and out of the organ to allow it to function similarly to a real organ. Kolff finally found success after the 16th patient in 1945. Kolff moved to the U.S. with his family and spent 17 years at the Cleveland Clinic working on artificial kidneys and hearts. Kolff successfully implanted an artificial heart into a dog in 1957, and the first human, Barney Clark, was implanted with an artificial heart in 1982. In 1999, Dr. Humes first utilized porcelain renal proximal tubule cells, which demonstrated some renal functions but was ultimately stopped due to some adverse effects and technical issues.
This technology will allow patients to grow an organ rather than be put on the donor list. At this point in time, not all organs can be grown or made, but as the technology in this area continues to advance, it will become more available to the public. In the U.S., kidneys are the most needed organ with over 600,000 people on dialysis. In artificial kidneys, a silicone membrane inside the bioreactor is used to protect the enclosed kidney cells from the host's immune system by keeping blood-borne immune cells and proteins out of the device. This eliminates the need for lifelong immunosuppressant drugs, which make the patient susceptible to infection. With the advancement in bioartificial organs, the need for donors will decrease as bioartificial kidneys could be used for a number of diseases, such as kidney failure, polycystic kidney disease, focal segmental glomerulosclerosis, and many others. It will also make it possible for patients to grow an organ rather than be on dialysis, which will improve the patient's quality of life. Organs at this time are also extremely expensive because of their high demand and low supply. The use of artificial organs will make them more accessible, as they are also extremely expensive at this time. Currently, a heart transplant can cost up to $1.4 billion, and an artificial heart can cost up to $300,000 initially. Bioartificial organs will help save many lives, as wait lists will not be as long. The patient can use their own stem cells in the organ, so it's a perfect match every time, although this may end up being expensive, as a heart can cost up to $1.3 billion in the first 5 years. The wait will be much shorter and will improve the patient's quality of life. Although there are numerous benefits, there are also few drawbacks for artificial organs. There are possible side effects like surgical trauma, scarring, infection, and increased fluid intake needed. There is also the possibility that some consequences are unknown as this technology is not common.
Artificial organs are often used as replacements and are commonly made of natural or synthetic polymers. They can also be made from metals, biocompatible plastics, ceramics like glass or carbon, and natural tissues such as stem cells. Polymers are often used because the material must be compatible with blood and any other bodily fluids that the organ may come in contact with. Polymers are already used to coat pacemakers to protect the electrical component from bodily fluids, with 100,000 coated pacemakers implanted annually. Since the organ is a replacement, it needs to be able to perform the same functions as closely as possible. Currently, there are many organs that can be made artificially, such as hearts, lungs, livers, pancreas, blood vessels, and parts of the GI tract. Another common replacement is porcine or pig valves, which are treated with glycerol or aldehyde to reduce the immune response. A company called Syncardia is developing a heart made of biocompatible plastic, which is intended to offer a high degree of fatigue resistance and long-term durability. They are using a biocompatible plastic as it should prevent the body from rejecting the organ and using an immune response to try and fight it. Right now, 70 cc artificial hearts have been approved for use in the US, Canada, and Europe. There are several factors that determine whether a patient will receive a donor organ, including blood type, size of organ, time spent waiting for an organ, distance between donor and recipient, if you are a child or an adult, and immune system matches. All of these factors account for the long waitlist times and are why some patients will be sick for years before receiving a new organ. The use of artificial organs will help to decrease the wait time for patients by 80%. New artificial organs shouldn't fail like donor organs might. There is also no need for the use of immunosuppressive drugs. Another advantage of artificial organs is that they are able to be mass-produced to meet the increasing demand. If there is a problem with the artificial organ, it can typically be fixed. The majority of artificial organs being transplanted right now are kidneys. There are 100,000 people on the kidney transplant list each year, and only about 18,000 people actually receive a transplant. In the UK, about 4,600 transplants took place from March to April 2015. The artificial organ market is expected to grow by 9.1% from 2017 to 2022. The demand for organs arises from accidents, lifestyle habits, diseases, and the deterioration of organs with age. Organs can be received from human donors, xenotransplantation, artificial organs, and the national organ donation. The supply is not able to keep up with the demand, even though there are more sources being developed to increase the supply of organs.
Artificial organs have the potential to be a large, life-saving industry. They will directly affect the healthcare system by making organ transplants more common and reducing the wait times for some patients. Currently, about 2% of Americans already have an artificial organ or joint, and this number will continue to grow as technology advances. In the UK, the demand for organ transplants has increased by 162% in the last 10 years. The need for kidneys is rising every year by about 8%, making organs more in demand. The need for organs is growing substantially, but the number of donors isn't increasing at a similar rate. It results in many patients staying on an organ donor list for years. The average cost of an organ is $20,000. Due to this, Global Market Insights estimate that the market value in 2025 is expected to be $30.9 billion US, which is about 40.2 billion Canadian. In 2018, an artificial pancreas segment cost $352.6 million. Currently, the end stage of renal disease treatment is covered by the government, and in 2016 this cost is about $35 billion in the US. It is predicted that artificial kidneys will save Medicare about $15 billion per year. It is estimated that the cost of an artificial organ is similar to a transplant, but this can't be determined unless human trials begin. After implantation, there will be costs, but these cannot be accurately measured until artificial organs are being used routinely.
X-rays aren't as commonly used to demonstrate soft tissue organs because there are other modalities that will better demonstrate them. MRIs are a common modality when imaging these soft tissue structures, such as organs. When imaging artificial organs in an MRI, the doctor must ensure that no metal is present in the organ, or it could be a danger to the patient. Metal is common in a lot of arterial stents and pacemakers, meaning the patient couldn't undergo an MRI. Metal in an X-ray and CT can degrade the image, cause artifacts, and increase dose to the patient. Scanning metal can result in photon starvation and beam hardening, which causes white and black streaks throughout the image. Any patients with a bioartificial organ, which have no metallic substances, would be able to undergo any type of diagnostic imaging, which ultimately improves their health care. A more in-depth look at one of these bioartificial organs is the kidney. Currently, the bioartificial kidney is being made, researched, and tested through what is called the Kidney Project.
End-stage renal disease afflicts 1.5 to 2 million people worldwide. When dialysis is available, it can be life-sustaining. But this short-term solution is time-consuming, expensive, and does not replace all of the functions of a healthy kidney. Meanwhile, a global shortage of donors means that hundreds of thousands of people die each year waiting for a kidney transplant. Scientists at UCSF are leading a research project with partners nationwide to help these patients. They're working to develop a small, implantable device that replicates many natural functions of the kidneys. Super-efficient membranes, created using silicon nanotechnology, will filter toxins from the blood without requiring pumps or electrical power. While a bioreactor containing specially engineered kidney tubule cells will perform other renal activities, maintaining appropriate water volume in the blood, electrolyte balance, and metabolic functions. These two advanced technologies will make up a small biocompatible device that attaches to the circulatory system and removes toxins to the bladder as waste. The artificial kidney will allow patients to live untethered from dialysis machines, eat and drink more normally, and live their lives more freely. Completion of this ambitious project will profoundly improve the quality and length of life for patients with kidney failure, as well as reduce the cost and personal toll of this devastating disease.
Patients with end-stage renal disease need kidney transplants, which are very hard to come by. Less than 10% of people needing a transplant can get one. Most patients put on dialysis, which struggles to remove large solutes and leaves uremic solutes untouched. 90% of patients need dialysis 3 times a week. However, it lacks endocrine and homeostatic regulation. It does not work as well as a kidney transplant, which has long-term benefits, and there remains a transplant shortage. The shortage in the future could be alleviated by these bioartificial kidneys. Dialysis and transplants can be successful, but have problems and limitations in quality of life for patients. A bioartificial kidney hopes to have healthy kidney functions, including solute clearance, homeostasis, metabolic and endocrine function, as well as avoid the big problem of organ donor shortage. Bioartificial kidneys do not require tri-weekly dialysis treatment, as it clears solutes and balances fluids on its own, and potentially leads to less complications, including infection or decreased quality of life. Hopefully, a bioartificial kidney can maintain bodily functions like metabolic and endocrine activity, blood pressure control, bone mineral metabolism, and lessened dietary restrictions. Bioartificial kidneys could act in 2 ways, either as a bridge therapy to kidney transplants or replace kidney transplants altogether.
The bioartificial kidney uses living membranes by coupling artificial membranes. This bioartificial kidney uses a hemofilter and cell bioreactor that gets rid of waste. The hemofilter processes incoming blood, and the bioreactor processes filtrate and puts sugars and salts back into blood for reabsorption. A hemofilter uses silicon nanotechnology to form a membrane. Along with the body's blood pressure, the artificial membrane filters similarly to kidneys without the need of pumps or power supply. The hemofilter must withstand the capillary perfusion pressure while filtering and ensuring protein loss is at a minimum. The cell bioreactor uses artificial tissue engineering to grow renal tubule cells. The bioreactor is needed to reabsorb salt and water and is used as a barrier to toxins and to regulate blood pressure and vitamin D. The bioartificial kidney is around the size of a coffee cup. Implanting the bioartificial kidney is similar to a kidney transplant surgery. The filter of the bioartificial organ is not expected to need to be cleaned as it's coated with a biocompatible film to prevent clots. In rats, scientists have been developing a bioartificial kidney from the mesoderm cells that come from the metanephric blastoma, which develops into nephrons, and mesonephric duct, which then further develops into collecting ducts, ureter, and renal pelvis. It has been shown in rats that developing a bioartificial kidney can be done by obtaining the metanephrons from an embryo and then placing the tissue into media with growth factors, which later gets implanted into the omentum where the kidney matures and becomes vascularized from host blood vessels.
The results of these methods in rats show that the urea excretion concentration was similar to the control group of rats used and suggested that implantation of larger renal mass improved excretion and outcomes. It also showed lower serum blood urea nitrogen levels, less proteinuria, and greater creatinine clearance, as well as less immune reaction in the transplants from embryo cells that were undifferentiated. The neo-kidneys implanted into the omentum also produced human erythropoietin that responded to anemia, and when left in the omentum for 4 weeks, the neo-kidney developed hydronephrosis with fluid containing urea and creatinine, which concludes urine-like fluid was being produced. These images show neo-kidneys from rats' omentum with newly formed blood vessels, shown by the white arrowheads in B, and also formed tubules and glomeruli in F. The kidney project does still have some problems to work out. One challenge is compacting the size. Requirements of size, pumps, and water volume are similar to that of what dialysis units use today. Other challenges including producing a similar cell structure to natural kidneys, which have uniform, elongated, slit-shaped fibers by using silicone nanopore membranes with slit-shaped pores. The challenge of availability of human proximal tubular epithelial cells capable of transepithelial excretion of uremic retention solutes, and developing a living membrane consisting of tight cellular monolayers maintaining their typical polarity and functionality are also challenges. There must be considerations made for bioartificial kidneys such as immune issues, as these have been an issue since the beginning of transplants. Finally, some also question if it is ethically right to use fetal cells and human embryos to develop the bioartificial organ through various techniques. There are still a lot of unknowns about bioartificial kidneys and organs, in which itself is an issue for some.
The Kidney Project is currently in stage 2 and is working with professionals to build and test multiple prototypes. They are working to improve the silicone membranes, hemofilter, cell bioreactor, and packaging of the bioartificial kidney. Currently, the Renal Assist Device, or RAD, is the only bioartificial kidney device that has been viable in humans to treat kidney failure. The RAD uses technologies of hollow fiber polymer membranes with cells on the inside which provide a mechanical and immune barrier, active transport, metabolic, and endocrine functions. The RAD has a hemofilter and cell bioreactor and is currently trying to be compressed in size to be acceptable for implantation functioning like transplanted kidneys. These technologies for bioartificial kidneys are promising, but will still need to be able to have viability in humans. In early human trials, no immunosuppressants or blood thinners were needed. Professionals are trying to determine if the hemofilter materials are safe for human blood exposure and if the hemofilter can sufficiently filter blood in humans. Bioartificial kidney models have shown success in animals, but it's still unknown what they will be like in adaptation for human trials. The Kidney Project aspires to be a permanent solution and to allow patients with the implanted kidney to self-monitor and reprogram the device, allowing for independent self-care and a normal lifestyle. The Kidney Project also strives for patients and doctors to be able to recognize potential device failure and how to fix it using minimally invasive techniques to replace filters and other components of the bioartificial organ. Overall, the Kidney Project gives hope to providing a larger number of patients the opportunity for a more permanent solution to kidney failure.